following episode is brought to you by the American Urological Association. The American Urological Association is accredited by the Accreditation Council for Continuing Medical Education to provide continuing medical education for physicians. For more information on how to claim CME credit or to view faculty disclosures, please visit the AUA University at auanet.org/university. Support for this episode has been provided by an independent educational grant from Merck Co, Inc.
Welcome to another episode of AUA University Podcast. I'm Dr. Mark Gonzalgo, Professor of Urology at the University of Miami and Chair of the AUA Office of Education. Today's topic is one that has rapidly evolved and continues to generate important discussion in our clinics and tumor boards: adjuvant therapy for renal cell carcinoma. Over the last few years, we've moved from a space marked largely by negative or equivocal trials to one with meaningful, disease-free, and overall survival data, alongside very real questions about patient selection, toxicity, duration of therapy, and shared decision-making. I'm delighted to be joined by Dr. Daniel Shapiro, Assistant Professor of Urologic Oncology at the University of Wisconsin, whose clinical practice and research focus on kidney cancer. Dr. Shapiro completed his residency at Wisconsin and SUO fellowship at MD Anderson. His work spans clinical trials, translational research, and immune signaling in the renal cell carcinoma tumor microenvironment. Dr. Shapiro, welcome, and thank you for joining us today.
Yeah, thanks so much for having me. I'm happy to be here.
So let's start with fundamentals for our audience. When we talk about adjuvant therapy for renal cell carcinoma, what do we mean and how did we get here?
Yeah, so adjuvant therapy traditionally is defined as treatment that we're giving as an additive therapy after we do like definitive local therapy. And it's typically applied in the non-metastatic setting. So that's kind of like the classical definition. Now, in some of the trials that have been published more recently, it's kind of been extended a little bit, and people have talked about giving adjuvant therapy after you've completely resected all metastatic disease. But in my mind, true adjuvant therapy is primarily used in patients who haven't progressed to metastatic disease.
Great. We know that over the years, a lot of the historical trials using VEGF and TKI in the adjuvant setting were largely negative. Now, do you have any insight into this? Was this perhaps more about drug biology, patient selection, or trial design, or a combination of all three?
Yeah, I think a lot of it is probably related to disease biology. And, we know that TKIs were somewhat effective, but not as effective as what we see with more like modern therapies. So if we look back at like what trials were done, there's multiple different trials that looked at different TKIs, but really there was only one trial that showed any sort of survival benefit, and that was the STRAC trial, which looked at sunitinib versus observation, and they did end up showing a disease-free survival benefit. Now that trial was interesting because that trial, if you look at all the other TKI-related trials, it had a higher risk population. So there is some trial design element that probably helped it show a survival benefit, but it only showed disease-free survival benefit and didn't actually show an overall survival benefit. So I think that really limited, widespread adoption and use of that drug. And even though it was approved, it wasn't used clinically very often.
Right. And, you mentioned it really not gaining any real traction in clinical practice. For urologists who trained during that era, do you think there are any other misconceptions from the VEGF experience that might still linger today?
I think the big thing is, people really want to see an overall survival benefit before they're willing to give adjuvant therapy. And, we can talk more about overall survival in the adjuvant setting and how it can be difficult to interpret an overall survival benefit when you're talking about adjuvant therapy. But I think, the big thing that really limited STRAC or sunitinib's widespread adoption, I think, was the fact that it never really showed an overall survival benefit. So if you're looking at more modern trials, when pembrolizumab did show an overall survival benefit, people were really excited about that. But I think there's a little bit of nuance when you're talking about overall survival and adjuvant therapy.
Oh, that's great. And that background really sets the stage for why the immunotherapy data has generated so much excitement. So let's shift gears a little bit and talk about the contemporary clinical trials. Which trials should urologists know about today when counseling patients?
Yeah, so so far, there have been, I believe, 5 published trials looking at perioperative immunotherapy. And obviously, we know immunotherapy is much more effective than the older TKI therapies, which is why they've been, explored very rigorously in the adjuvant setting now, because we've seen a lot of benefit in the metastatic space by incorporating immunotherapies. And so far, there have been 5 published trials. There was Prosper, there was Emotion 010, and then there were 2 Checkmate 914 trials that were split into 2 components. And then the big one was Keynote 564, which was published in 2021. And I think Keynote 564 is the big one that, for trainees and practicing urologists is the one that we really want to know about, because that one looked at adjuvant pembrolizumab and compared it to just giving surveillance or placebo. And that actually did show first disease-free survival benefit, but then subsequent longer-term follow-up, they did actually show an overall survival benefit. And so that led to FDA approval of adjuvant pembrolizumab, and now it's being routinely given in the adjuvant setting for high-risk patients.
That's a great point. And, focusing on that particular Keynote study, as urologists and practicing clinicians, we can understand these concepts of disease-free survival and overall survival benefit. But when you're explaining Keynote 564 to a patient, what's the single most important nuance you want them to understand about the benefit and results of the study?
Yeah, I mean, it's hard to narrow down to just like one benefit. I would say, one thing all kidney cancer patients come in saying after you do surgery is, what can I do next? Is there anything I can do to make sure the disease doesn't come back? And so when we're thinking about Keynote, the first thing is, it only fits certain criteria of patients. So it's important that the patient understands whether or not they're eligible. And so strictly speaking, adjuvant pembrolizumab is really only approved for patients with clear cell RCC and then patients who have the high risk features. So the eligibility criteria for Keynote was T2 disease that was grade 4 or sarcomatoid features, and then anyone who had T3 or higher disease. And then also there were some patients who were completely resected that either had nodal disease or metastatic disease, but had to be completely resected. So that's kind of the first thing I talk about with patients is, are they eligible or not? But then it really gets down to the nuance of the interpretation of the trials. So I think when we're talking about adjuvant therapy, it's really important to understand the benefits versus the risk. And when you're talking about adjuvant immunotherapy, toxicity can be pretty significant. So if we look at adjuvant pembrolizumab, the high-grade toxicity rate was in the 20 to 30% range. And some of those toxicities can be life-altering. So I think it's really important that we understand the disease-free survival benefit, but also weigh that with the potential toxicity and having that conversation with the patient and figuring out, are they willing to accept the risk of toxicity with, not 100% benefit. We know that the disease-free survival, if you look at the actual risk reduction, patients are only getting about a 10% per year benefit in improving their disease-free survival. So that's not like a slam dunk, hit it out of the park benefit by giving adjuvant therapy.
Right. And I think those are excellent points that you've made, especially when it comes to patient expectations and the reality of what these medications can do. Several trials were actually negative, and I think we acknowledge that. Do you view that as the failure of the immunotherapy in a broad sense, or is that more evidence that patient selection might be the real differentiator?
Yeah, I mean, that's really the million-dollar question. I think we debate this a lot, and I've thought a lot about this, and we could have a whole podcast just on this, but I think a lot of it, in my opinion, came down to the Keynote study really had a successful design. I think it's hard to argue that, they all tested effective immunotherapies. And so it's hard to argue that one immunotherapy is potentially more effective than another, and that's why the trial failed. I think what's really interesting about the Keynote trial is that trial was really powered effectively to determine a disease-free survival benefit. So they enrolled one of the highest risk populations. They had a very homogeneous population, so they only included clear cell RCC patients. And so that, if you're including other subtypes, that can affect how many events you have, and then that can affect whether or not you see an actual signal. And so if you look at like all the ways that that trial was designed, I think it was just a very effective trial design that led to a very high trial power, which makes it much more easy to find a signal and a benefit for the drug. Whereas if you have a lot of noise in the data, then it's hard to see any sort of signal. So I don't really think of the other trials as being negative. I think of them more as inconclusive. Perhaps if we had run the trial in a different way using that same drug, we would have actually found a different outcome, and maybe there is some benefit for those drugs. But as it stands right now, only pembrolizumab is really used clinically in the adjuvant setting.
Okay, no, very good points. And even with positive trials, I think it highlights the fact that designing these studies and applying them to real patients is anything but straightforward sometimes.
Yeah.
Shifting gears to trial design challenges and some potentially unanswered questions, what do you think are the biggest design challenges in perioperative and adjuvant renal cell carcinoma trials?
Yeah, I think I think one of the biggest issues and what it really comes down to is we need to identify those patients who are really at the highest risk of having a recurrence. Like if you look at the Keynote study and a lot of the other adjuvant immunotherapy studies, even though these patients are considered quote unquote high risk, still about 50%, 70% aren't actually developing any disease recurrence over the study period in the placebo arm. So a lot of these patients we're just curing with surgery alone. So if we want to design an effective trial, it all comes down to how many events you have. Like patients there need to be some recurrences so that we can see a difference. And so we need to have better ways of identifying which patients are going to recur. And that really comes down to prognostication. And so we need better ways beyond just the traditional clinical and pathologic risk factors that help us identify those really high-risk patients so that we can then enroll these trials with patients who are at most risk of having a recurrence. Because I think a lot of these trials get diluted because a lot of these patients just do really well after surgery and don't really need any adjuvant therapy.
Now, we recognize that there are many challenges with trial design. And so I'm going to ask you a question here. If you were designing the next generation adjuvant renal cell carcinoma trial today, what do you think you might change first?
Yeah, I think there's quite a few things. I think increasing the sample size, I think, is one of the, a lot of times we set out these predefined sample sizes or, and our enrollments for adjuvant trials really need to be almost higher than what we see in the metastatic setting because we just don't have as high of an event rate. So if you look at some of the more effectively designed trials like Keynote 564 and now LightSpark 022 hasn't been published yet, but they did announce that it met its primary endpoint. These trials had some of the highest sample sizes. So again, you're more likely to see an effect of the drug because you have a higher trial power. So I think one thing is, just increase the number of patients that are being enrolled. Also, developing better biomarkers so that we can actually determine which patients are at highest risk of developing a recurrence. And so that's some research that I'm participating in and many others are looking into. And then trying to integrate those biomarkers into trials may be helpful as well to kind of, identify the highest risk patients. So, I think those are some techniques that we can look at.
Thank you. You mentioned biomarkers. Obviously, these are important variables that have entered many segments of the disease states that we treat, particularly in oncology. And as we begin to incorporate this type of data into a clinical practice, it begs the question of whether we're really truly getting closer to that precision adjuvant therapy. In your opinion, where do biomarkers fit into this moving forward?
Yeah, well, unfortunately right now, kidney cancer lacks any very effective or routinely used biomarkers. There's a lot of studies that are going on. And actually, I was fortunate to co-chair a think tank with the Kidney Cancer Association last year where we kind of set out some priorities for biomarker development. But so far, we don't have anything routinely used. I think there are a few biomarkers coming down the line now that are being actively investigated. We're kind of always following behind bladder cancer, and ctDNA is a big one. The problem in RCC is traditionally RCC was kind of a low ctDNA shedding tumor, quote unquote, low shedding. But I think there's been improvements in assay designs and different platforms that maybe will make it easier for ctDNA to be detected in patients with RCC. And then there's other biomarkers. There's a biomarker called KIM1 or kidney injury molecule 1 that's being very actively investigated. And that's a protein that's essentially shed from the kidney cancer cells, particularly clear cell RCC. And that seems to have some prognostic benefit in both the non-metastatic and the metastatic setting. And so, there's still a lot of work that has to be done. A lot of these biomarkers have to be validated. Most of the studies so far have all been retrospective or kind of post hoc analyses of clinical trial biospecimens. So, there's still a lot of work to be done in terms of bringing these biomarkers into clinical practice. But I think that really is kind of the key to moving forward. I think we've kind of are reaching the limits of what we can do with, the TNM staging and clinical risk factors alone in terms of figuring out patient prognosis.
Realizing that this is a rapidly evolving area, if I were to ask you the question of which biomarker strategy you think is closest to real-world clinical adoption, what do you think that would be, and what still needs to happen maybe to get us there?
Yeah, I think, KIM1 certainly has had a lot of research done on it so far. I think ultimately, though, it's probably not going to be one biomarker alone that's going to be sort of this holy grail of we just check, this one biomarker and it'll give us, a perfect estimate of a patient's prognosis. I think what it's going to come down to and what I've been trying to investigate in my lab is developing these integrated biomarkers where we're combining, things like ctDNA, KIM1, and clinical risk factors into a better risk model. And so that each of these biomarkers is giving, kind of incremental benefit, but overall the model is it outperforms, either any of these biomarkers alone. So I think ultimately it's going to come down to an integrated multimodal model.
You mentioned some important themes when we are talking to our patients about these options after surgery. So I wanted to bring this back to the clinic in terms of real world counseling and toxicity management. How are you counseling patients today when it comes to adjuvant therapy for renal cell carcinoma?
Yeah, I think what I typically, I start out, like we talked about earlier, I start out just clarifying whether or not they're eligible, because that's obviously the most, that's kind of the first check mark. But then it gets into a discussion of sort of risks and benefits. And so I talk about, the absolute risk reduction by giving adjuvant therapy. I quote about 10 to 15% per year. So, but then I quote, a potential high risk toxicity, things like pneumonitis, myocarditis, colitis, is also about 10 to 15%, potentially even higher. And so, when patients hear these numbers, it kind of puts things in perspective. And I would say, a lot of patients, when they hear the risk of the toxicity, it kind of outweighs the benefit that they see. And so I still have a significant number of patients that will ultimately end up choosing just surveillance alone, knowing that if they do recur, that we still have immunotherapy available to them in the future. However, if we have younger patients, particularly with high risk features like sarcomatoid disease or larger tumors, things like that, then, they maybe want to be more aggressive. And so then adjuvant therapy makes sense for them. And then, I refer them to medical oncology and they go from there. So it really gets down to what the patient's priorities are, how willing they are to accept the potential toxicity. So it's a very individualized conversation. It's kind of made my conversations post-operatively with patients a little bit more. It's a longer appointment now than it used to be. But I think it's good. And patients really want to do everything they can, but I think it's important to highlight the toxicity, which is real. And we actually looked at our institutional data, and we're sending about 20 to 30% of patients ultimately end up wanting to get adjuvant therapy. So it's still, there's a significant portion of patients that end up just choosing surveillance, which I think is reasonable.
Along those lines, are there any particular patient characteristics, whether they be medical, psychosocial, or logistical, that make you more cautious about recommending adjuvant therapy?
Yeah, I mean, certainly performance status is a big point. More elderly patients or people with other comorbidities might be less likely to recommend adjuvant therapy. It does require, obviously, infusions currently. So patients have to be willing to go to get their infusion at infusion centers, and it's usually about a year-long therapy course. And then obviously, there's certain contraindications to immunotherapy. If they have other autoimmune diseases, things like that, obviously they wouldn't be eligible. So, but I think, there's the people who are kind of more elderly, maybe not as great of a performance status. Those might be patients that I'd be less enthusiastic about recommending immunotherapy. But, it's a very individualized approach.
Great. And as we wrap up, I want to ask you one final question. It's kind of at a high level, and you can answer it in any way that you may see fit. And that is, if you had to leave urologists and those listening in the audience with one or maybe two practical takeaway points about adjuvant therapy for renal cell carcinoma, what would it be?
Yeah, I think, it's important that if you're talking about immunotherapy and adjuvant therapy, I think it comes down to experience. And, a lot of times we aren't the ones ultimately giving the therapy. And so having a multidisciplinary team who's experienced treating patients with kidney cancer and kind of understands the nuances of the literature and treating these patients, I think is really important. So, having that multidisciplinary team that has experience is really critical. And then, it gets back to, this is a very individualized decision. I think it's important that we don't just knee-jerk send everyone to get adjuvant immunotherapy. I think it really requires a nuanced discussion, understanding what the patient's priorities are and how willing they are to accept potential toxicity before we, recommend giving adjuvant therapy to everyone, even though it's FDA approved.
Well, Dr. Shapiro, this has been a terrific discussion. You've clearly outlined how adjuvant therapy for renal cell carcinoma has evolved, and just as importantly, how to apply these data thoughtfully in real-world practice. The key message for our listeners is that adjuvant therapy is really no longer just a theoretical option. It's really now a meaningful tool for selected at-risk patients, but success depends on patient selection, counseling, and careful toxicity management. And to our listeners, thank you for joining us. For more high-quality educational content, including courses and clinical updates, visit auanet.org/university. I'm Dr. Mark Gonzalgo, and we look forward to bringing you another episode of the AUA University podcast.